Hello, my name is Amy Clements-Cortes. I'm assistant professor at the University of Toronto in the Faculty of Music, instructor and supervisor at Wilfrid Laurier University in the Music Therapy Department, a registered psychotherapist, and a credentialed music therapist. I'm very honored to be here today to talk to you as one of the spotlight speakers in the Ethical Challenges in Music Therapy Spotlight Speaker session. I will be speaking specifically about medical assistance in dying, looking at the challenges, considerations, and implications for music therapists. So to overview the talk, I'm going to give you a definition of what is medical assistance in dying. I'm going to look at the ethical implications for stakeholders, the ethical issues of music therapy in MAID, the role of music therapy in end of life, the potential role of music therapy in MAID, and then to look at future directions and research. But let's begin with a definition of what is medical assistance in dying. So essentially, medical assistance in dying permits individuals with terminal and grievous physical or psychological suffering to end their life using pathological means in the company of healthcare professional, such as a physician, a nurse, or a pharmacist. Definitions of MAID vary around the world, and MAID currently is available in Europe, Australia, North and South America. Some of the legislation has some terminology and some implications that are not so clear. So for example, in the German legislation, while it does not criminalize suicide, it prohibits facilitation by a physician. On June 17th in 2016, Bill C-14 was passed outlining two types of MAID that include two forms of suicide that are legal in Canada: physician-assisted suicide, which is the self-prescription of a lethal oral medication by the patient, and voluntary euthanasia, which is the administration of a lethal medication to the patient by a medical practitioner. Individuals may receive MAID if they meet a number of criteria. So for example, the minimum age requirement to make a competent medical decision is 18 or older. They must have the diagnosis of a serious or incurable illness, disease, or disability that is presented in advanced stages, irreversible or with irreversible decline. Experiences of intolerable physical or psychological sufferance from the illness, the disease, the disability, or the state of decline that cannot be relieved by acceptable alternative methods, and natural death becomes a reasonable and foreseeable future which considers the patient's medical circumstances and remaining time of living. So where do ethical implications arise? So the stakeholders are the patient, they are the medical and healthcare professionals, as well as the community. So let's begin with the patient. Patients eligible for MAID expressed affirmative outlooks and feelings of control and autonomy with respect to their suffering. Many choose MAID due to a fear of future pain and suffering, a decreased pleasure in activities that they had enjoyed previously, feeling that they are somehow a burden to society and a burden to families, as well as challenges in communication. Ethical issues arise when individuals qualify for MAID, for example, but are left for long periods of time before the procedure takes place. So sometimes that could be the terminology. In Canada, for example, we have the terminology reasonable foreseeable future. But this does not guarantee that the procedure will be provided in any kind of expedited fashion. In fact, Buethin in 2017 found that in Canada, patients were waiting up to 5 years for the procedure in a number of cases. Safeguards, while very important, also cause further hardship, suffering, and delay. In Canada, there must be an assessment by two medical professionals not working together, and a required 10-day waiting period from the time of the written request until the time of the procedure, and that the individual must also remain able to provide consent and demonstrate capacity at the time of the procedure. These factors may cause patients to re-examine MAID as delays of the services cause additional suffering. So for ethical implications of medical and healthcare professionals, physicians and nurses who provided MAID procedures after the bill was passed in Canada reported feeling honored and that it was a large responsibility, but there were also many practical challenges. For example, the safe disclosure of personal opinions. In a Canadian family medicine residency program, 45% of residents and 33.3% of preceptors reported they felt competent in facilitating MAID, which is debated by the incomplete amount of education and fears regarding professionals feeling safe in disclosing personal opinions about MAID in medical environments. The definition of medical and healthcare professionals also presents ethical issues, as the list is very ambiguous. Narrow research supports a variety of mental health practitioners, for example, psychiatrists and music therapists, as valid stakeholders. Also important is to look at who wrote the legislation. By and large, it's a political community that has written and revised the legislation, and the ethical challenge that may factor in here is if the medical and healthcare community may not have the same professional language and practical knowledge. Medical and healthcare practitioners may also be faced with legal and professional practice challenges if there is a disagreement regarding a patient's eligibility for MAID, and their protection as facilitators may therefore be reduced. In Canada, revisions of Bill C-14 could help in resolving or having a structure for anticipated logistical challenges in clinical practice. It might not seem so at first, but the community can also be impacted with ethical implications. For example, family and friends of an individual who qualifies for MAID are not exempt to the Canadian Criminal Code, and as such, it can limit the patient in requesting a kin to be part of their MAID process. In faith-based healthcare facilities, there is a lot of controversy surrounding MAID, and there are also clinicians' personal religious beliefs who and professional physicians that campaign for religious exceptions to the Canadian bill. What we need is further legal interpretation that delineates kin and caregiver perspectives. There are several ethical issues that can be addressed with medical and healthcare professionals, primarily as well that would extend to music therapists. These include music therapists and their choice of MAID administration, policies and guidelines for MAID implementation, as well as assessments and determining patient eligibility in MAID. While MAID is a legal patient option, medical and healthcare practitioners have been found to be reluctant to provide MAID based on the scope of their clinical work. Canadian healthcare professionals are not obligated to provide MAID. However, if the physician does decline the process, they are required to provide a referral to who will administer the procedure on their behalf. As noted by Hoon Brown on your screen, just because doctors are regularly exposed to death doesn't mean they're comfortable performing euthanasia. So with respect to the field of music therapy, that issue is solved practically. Practitioners can refer the individuals to another physician and nurse because there is generally a large pool in any organization, especially compared to music therapy. But what happens when an organization employs a music therapist who is not comfortable in providing MAID? This situation can raise questions about the capacity of the healthcare organization to look for another music therapist, the additional costs, and the possible inability to appoint a secondary music therapist. These issues can impact the patient's request for MAID services and place tension or harm on the client-to-music therapist relationship. Although it may be a rare scenario for a patient to request a music therapist in the MAID procedure, there is a clear responsibility that we do need to provide this type of service. Further, healthcare professionals can experience a range of emotions in the MAID procedure, which places additional stress on them and their physician. Buethin and colleagues in 2018 expanded on this and shared an example of a group of nurses who had experienced emotional distress while providing care to a patient considering MAID. In addition to the stories of being positively impacted, nurses also described a range of emotions, some anticipated and others not. Music therapists may not have the option of participating in team debriefing or support groups to support them and help them regulate and process their acquired emotions from MAID, as the majority only work part-time in these settings, especially in Canada. This can result in professionals feeling isolated and emotionally vulnerable. Further, Buethin and colleagues in 2018 found 3 qualitative themes in the nurses' perspectives of providing care in MAID. Nursing was a profession that aspired to provide holistic care without judgment, advocated patient choice, and supported a good death. Nurses were well-respected pioneers in the healthcare system and understood that their emotional well-being and choice in their participation in MAID was valued. And comfort and competence were the nurses' priorities when they were interacting with patients who were seeking MAID. These themes support nurses as well as potential MAID practitioners, including music therapists, showing that they require a healthy regulation in their emotions so that they can deliver quality services for their patients that is representative of their profession. In Canada, MAID can be administered by physicians. However, physicians and healthcare practitioners were not formally trained in this procedure during their schooling. This claim is further supported by the limited amount of resources or guidelines that are available for these professionals to reference on the appropriate performance measures of MAID. At the Princess Margaret Hospital, Dr. Madeline Lee, a Canadian physician, tasked an interdisciplinary team of health professionals to develop policies and procedures that outline the delivery of MAID. Lee states, "We are actively ending a life, and it's very new to us." Her comments support the need to establish a standardized methodology of the MAID process to the practitioner's perspective. The quote serves also as an ethical dilemma in the practice of medicine and music therapy, considering the role of a physician foremost is to save lives, cure illness, and MAID is quite the opposite. At present, there are no clinical guidelines for music therapists to base their work with patients who have requested MAID services. I'm very pleased to share that a special interest group titled Music Therapy, Medical Assistance in Dying, facilitating a collective approach to creating clinical guidelines and implementing evidence-based practices, has been formed by Dr. Sarah Rose Black, music therapist at Princess Margaret Hospital in Canada. The mandate of this group is to develop a series of clinical guidelines for music therapists in the engagement of MAID. The team is made up of not only music therapists, but other healthcare professionals, and I'm very honored to be a part of that team. Bill C-14 in Canada explains patient eligibility for MAID, which is grounded in a number of safeguards I spoke about earlier. These safeguards, however, create ethical dilemmas. For example, the bill does not take into account that an individual's cognition and physiological condition may decline while waiting for the MAID procedure. Due to the nature of a number of illnesses, cognition may decline from an individual being able to make a competent medical decision to being in a state of dementia. One way to circumvent such challenges would be to create advanced care directives and an honor system to ensure a cognitively impaired individual would be eligible for MAID without having to demonstrate informed consent when the MAID time arises. A challenge in advanced care directives would be in determining a date for the procedure, given that an individual has little control over the disease progression. Creating a predetermined date for MAID would seem inaccurate in capturing best medical and healthcare practices. Both passive and active music therapy techniques are used in end-of-life care, such as improvisation, singing, songwriting, lyric analysis and discussion, among others. And these techniques are used to achieve a variety of goals in all of the domains, including the physical domain, the psychosocial, spiritual, etc. On your slide, you'll see some of the earlier references that support the role of music therapy in end-of-life care. So for example, reducing spiritual distress, reducing anxiety, decreasing blood pressure, heart and respiratory rates, as well as pain perception, assisting with life review, and facilitating reminiscence. On this slide, you'll see a little bit more up-to-date view of some of the studies. So, for example, Vessel and Dave in 2018 found that music therapy supported pain management, increased energy and quality of life, while also decreasing anxiety as measured through self-report. Schmidt and colleagues in 2016 showed that we had support in terms of pain management, control over self-regulation of emotions, increase in positive relationships with others as well as themselves, improvement in physical symptoms, relaxation, and physiological symptoms, things like heart rate, blood pressure, Gallagher and colleagues showed improvements in patients' mood levels, stress and anxiety, perceived pain, overall quality of life, and acceptance of death. McConnell and Porter in 2017 showing improvement in physical comfort, among other measures. Gutskell in 2013, again showing perceived pain decreased, as well as improvements in pain management. And finally, Worth and colleagues in 2016 showing support for improvements in relaxation and wellness, as well as in physiological symptoms like heart rate and blood pressure. And these are just some examples that I pulled from the literature for us. Due to the continual integration of music therapists and healthcare teams in work with individuals at end of life, music therapists may be called to offer the MAID procedure. According to Black, music can play a role at any point in a person's experience of illness and can equally be offered at any point during MAID, including during the assessment period, as well as the actual time of intervention, depending on the person's preferences and wishes. At the end of life, music therapy is a natural extension to MAID services. For example, music psychotherapy can enable the psychosocial processing of an individual's emotional and mental states while serving as a reflective tool to create opportunities for discussion, which is important to the client and for the client to discuss meaningful things in their own life. I'm going to share a hypothetical case that I wrote regarding an older adult who has been receiving music therapy in an inpatient palliative care unit and is now considering MAID as his pain is escalating. The rationale for presenting a hypothetical case is that to date, no formal research case studies have described the inclusion of music therapy in the MAID process. So consider the case of Blake. A music therapist has been working with an end-of-life patient named Blake to achieve relationship completion with his partner, Paul. Paul has been present at the majority of music therapy sessions, and together they have engaged in clinical improvisation as well as songwriting to help them express important sentiments to each other, such as "I love you" and "thank you." Blake had considerable pain which had been well controlled in the past few months when he first received his diagnosis of a terminal illness. However, the past few weeks the pain has been escalating and Blake expressed a desire to have the MAID procedure. He had formed a therapeutic relationship quickly with the music therapist, and he felt strongly about having music therapy as part of the MAID procedure to help him relax and stay connected to his identity as he passed from this place to the next. He asked the music therapist if they then would be comfortable providing music, and the music therapist agreed. Together in the days leading up to the procedure, they picked music Blake would like to have played, which includes songs he had written for Paul, as well as songs they had composed together. MAID is a somewhat new procedure that necessitates further documentation in its success to ensure patient autonomy. There definitely is a responsibility for healthcare professionals as well to be writing about their work and dialoguing, as well as to ensure the safe and effective use of self. There's implications for family caregivers as well as faith-based communities. And what we can see really is that there's a need for research, descriptive writing, and definitely guidelines for the various healthcare professionals. The role of music therapists in palliative care has demonstrated robust potential in their ability to assist MAID procedures. Future research is suggested to evaluate potential legislative amendments to Bill C-14 in Canada based upon personal experiences of healthcare practitioners, including music therapists, as well as for patient safeguards, which have been limiting. As well, researchers should evaluate the ethical issues of MAID in palliative music therapy, which includes the availability of these specialized professionals to perform MAID and the possible strains that may arise in future client-facilitator relationships. So I've provided just some selected references on the last few screens for you. I want to thank you very much for your time, and I look forward to meeting and dialoguing with the question and answer period. Thank you very much.